Clinton with the Heart of Medicine, and this is video number 19. So 19 days straight, sharing with you guys the main clinical pearls as I prepare for the internal medicine certification exam, ABIM, before moving on to cardiology. And as I have already said in the past, I'm making these videos to make it easier for you to learn internal medicine while you might be busy doing things during the day. And of course, I understand that there are time constraints and that many of you might get out of the hospital and not have time for anything. And maybe all the time you have is a brief 30 minutes while you are driving back home from work. So this video might help you out. If not, it definitely helps me out to be put in a tough spot trying to explain my weaknesses and how to overcome them. So I'm going to go through the main clinical pearls. This is not just me saying the educational objective. This is me walking you through my mental framework and how this can benefit you when you go through these tests. And yeah, so let's go on to the action. This first question is very important because it's part of that high value care. It's basically telling you when do you order a test, when do you not order a test. So this patient is a 45-year-old man. He twisted his ankle. He doesn't know in which way. He doesn't know if it was eversion or if it was inversion. Only thing he has is a lot of ecchymosis and edema and a lot of swelling in the lateral aspect of the ankle. So here's where I want you to pay the most attention. So there is no tenderness at the posterior edge or tip of either malleoli. There is no pain at the base of the fifth metatarsal, and palpation of the navicular area of his foot does not elicit pain. Which of the following is the most appropriate next step evaluating this patient's injury? So as you can see right off the bat, I was able to rule out things that didn't make much sense. Coagulation studies, no. CT of the ankle, no. But you could potentially make a case of two options, which are no imaging studies at this time. Okay, you got a potential runner up there, and the other one is radiographs of the ankle. So if you put yourself in the hospital, right, and you're an internal medicine resident or you're most doctors out there, it's not that straightforward. You're probably not an orthopedist. Maybe of course, for an orthopedist, it would be easier. But most of those patients you see in the emergency department, I had to see several patients with these ankle injuries. Most of them would go home back with an X-ray. That was like the bare minimum, and a little bit of ice, rest. What is it? The RICE sort of therapy is rest, ice, compression, elevation, basically. So yeah, that was it. But if they're telling you, remember that if they're telling you several things and the question, everything you have that is here, you have to pay attention to. So they're telling you that there isn't pain here, there isn't pain there. So I always remember when I had to see these patients in the emergency department, you always do this sort of, you grab onto the malleoli on both sides, you press on it, because that, if there's a fracture, boom, when you press on it, the pain is going to be exquisitely tender. And you might even feel, if the malleoli is broken, a little bit of movement, right? Usually the medial malleoli, if it's painful and if the patient has a fracture, the patient probably cannot walk, cannot bear weight on it, because if the tibia is fractured, you probably cannot bear weight on it. You're gonna just come in the hospital limping and jumping in a wheelchair. But if you can bear weight on it, well, you can still have a fracture. For example, the fibula in the lateral malleoli can be fractured. That gives you the stability of basically of the stance, but it doesn't necessarily bear the weight. So yes, you can have a fracture and the patient can come in walking with difficulty or slowly. But when you do this pinching, right, there's no pain. So they're giving us several different clues here, and these clues have a name. So I had forgotten the name about what this clues or these physical examination is. It starts with an O, and it's called the Ottawa rule. So if you do the Ottawa rule, basically this is what was done here. So you check the posterior edge or tip of either malleoli, you check the base of the fifth metatarsal, palpate the navicular area of the foot. So all those didn't have special pain. Yes, there was ecchymosis and there was swelling, which is expected. But if all that on physical examination is negative, that is telling you that the Ottawa rule is negative. So the Ottawa rule is basically this set of physical examination findings that would suggest if further imaging is required. So since clinically this patient had all these negative, you don't have to go pursue any additional imaging. So even though you might not know the exact Ottawa rule, if you just think of these things thoroughly and use a little bit of common sense, you can also diagnose, or you can also get the question right. Because the way I saw this question, I thought to myself, like, what would I do in the emergency department? That's always important. If you have experience with these patients, it's always important for you to think about what would be done in my hospital. What have I seen in the past? That doesn't mean that's going to be the right answer. Remember that there are a lot of things that are made just out of habit, and not all experience is good experience. So you just have to think, okay, was that thing they were doing in my hospital, or was that thing I was doing the correct? So you have to face it with now a challenge, which is what would be the most appropriate thing to do. So if they're asking you these questions, remember that there's a subset of questions that are just going to be high value care, which makes sense, which is telling you, hey, use resources wisely. So if you see that in physical examination, there is a no this, no that, and everything's looking normal, they're giving you a patient that is sort of fine, and the patient does have some expected findings. So that's how I ruled this out. And I thought to myself, yeah, the most probable answer here is either no imaging or an X-ray. Okay, I'm fine with that. And then I thought to myself, why would I still pursue an X-ray if they're telling me that there's no pain here or there? So probably they're just trying to tell me these physical examination findings are not showing any fracture. Probably not have to work this up anymore diagnostically. And that was the correct answer. So now let's just focus on the Ottawa ankle rules. So basically here you can see X-ray of the ankle is required if pain at the malleolar zone, okay, malleoli, and so not only pain in the malleolar zone, which you can see here in blue, and you will need one of these, one of any of these. So one is tender at posterior margin or tip, or sorry, of medial malleolus, or tender at posterior margin or tip of lateral malleolus, makes sense. Or the patient is unable to bear weight 4 steps. So two on each foot. So you don't have to make the patient walk till the end of the hallway. You just have to see 4 steps in total. So 2 steps on this foot, 2 steps on that foot. And if the patient cannot bear weight, well, that's an indication for a X-ray. And you also need another, let's see, that was X-ray of the ankle. Now let's consider when you need an X-ray of the foot, which of course, most of those X-ray that you perform on the ankle, the field of view also shows you the foot, and it's usually not isolated only to one specific place. At least I recall that whenever you had an ankle sort of injury, the X-ray would show you the entire foot as well. So probably that's gonna be the case in most cases out there, but at least for you to know when to focus on the foot and when to focus on the ankle, well, you have this. So when would you need an X-ray of the foot? So pain at the midfoot zone. So now we're talking about the midfoot. We already talked about the malleoli. Now this is the midfoot right here. So that is sort of where the right before the metatarsus, right? The metatarsophalangeal area. So metatarsophalangeal would be this metatarsophalangeal joint. Well, before that joint is going to be where the sort of midfoot is going to be localized. So you need pain there, and what else? You need the patient to have a tenderness at the navicular, or tender at the base of the fifth metatarsal, which is shown here. Which one was the navicular? Oh, here it is. They're showing us the navicular. Good thing, because I wanted to remember that anatomical landmark right now. So the navicular is the bone that is in the medial aspect of the medial aspect and midfoot. That's the navicular. The other one is, so medial or lateral. The lateral would be base of the fifth metatarsal, or unable to bear weight, 4 steps, same thing, 2 steps on each foot. So now we know this rule. The Ottawa ankle rule is very specific, so it's not specific. If it's positive, it doesn't tell you where the fracture is, right? It doesn't necessarily tell you if there is a fracture. It might be something else, but it is highly sensitive. And remember that its sensitivity is, well, almost 100%, meaning that tests that are highly sensitive have a high negative predictive value. So the worth of the Ottawa ankle rules is that if it is negative or normal, then you don't have to pursue any more imaging because there's no fracture. But if it is positive, you have to go pursue imaging, because maybe yes, maybe no, regarding problems there. Right? That's basically the main pearl with this. And the other things we could talk about this question is that when would you do a CT? Or basically, if you have to pursue imaging, which is your best image? It's an X-ray. If the X-ray is non-conclusive, what would you do? You would do a CT scan. When would you do any MRI? Well, remember, MRIs are not that good for bones, so that's more for seeing ligaments. But would an MRI here change management at all? Probably not. So it's mainly a decoy. Now let's move on to this next question. They give you this image. They tell you it's a patient that immigrated from Mexico. The patient does not have HIV, only has had diabetes, and I think the patient is in his 40s, and they're just asking you what's the diagnosis, what's going on. They also tell you that this patient had a seizure recently, and had seizures I think many weeks ago. So they show you this, and they give you the options, and the main choices that I had difficulty between were one was toxoplasmosis, another was neurocysticercosis, and I'm just going to give you a couple more. Another one was tuberculosis, brain metastasis, and embolic septic emboli. Okay, so just looking at the image, of course, on the quiz mode, they don't give you this additional information here. So I wasn't able to, like, I did think something was going on here with the ventricles, right? Which one was this? Was this the lateral ventricle? I think these were the lateral ventricles, and this one, can't remember if that's part of the lateral ventricles right now. Let's just Google it real quick. Brain ventricle anatomy. So let's just see that real quick. So it would be this big one right here. So it would be the lateral ventricles. That's part of the lateral ventricles. And let's just confirm this with another view, which would be here. Yeah, here you have body of the lateral ventricle. So it would be like the anterior horn or anterior aspect of the lateral ventricle. Okay, going back to this. So you're seeing, like, I did see, like, it looked like more obscure, or it looked darker in a bigger area. So I did think like there was something going on, but I didn't actually think, oh, this is hydrocephalus. No, I didn't think about that. I didn't make that association, but okay, now you have it there. There was hydrocephalus, and that was actually what was generating the patient's symptoms of seizures. And so a couple of seizures. I also didn't coin that together. I focused on the calcifications, which you see there, several calcifications. And I thought to myself, okay, what is this? So this wasn't giving me any history concerning for septic emboli. The patient was not febrile, and I wouldn't expect to see this with septic emboli because it looks like too circumscribed. So I was between toxoplasmosis and neurocysticercosis. Okay, so how could I differentiate between both? I got this one correct. Because I recalled that toxoplasmosis will just not happen in an immunocompetent individual. And they weren't telling me that this patient was immunosuppressed in any way or form. So basically with that, you should say, okay, this isn't toxoplasmosis. Neurocysticercosis due to Taenia solium can actually happen in immunocompetent people. So you're just in the probably incorrect place at the incorrect time. So they told us he immigrated from Mexico. So whenever they tell you this patient immigrated for X, Y, Z, you have to consider, oh, maybe it has something to do with the immigration status. And well, this happened because pork is usually nearby places that have human feces. So the pork eats I think the person has the tinea, and the person excretes it through the feces in like an immature form. Then the pork eats the feces. Then the cycle of this parasite continues to evolve, and then someone eats the pork without cooking it well enough, and then it becomes this thing that can go to the brain. So these are calcified nodules or granulomas, and this was neurocysticercosis. So that's the main thing with this. It usually will manifest 3 to 5 years after the symptoms, right? Usually the patient is asymptomatic, but can become symptomatic when the cysts become the start to degenerate about 3 to 5 years after all this started. Imagine that. That's crazy. And yeah, that's the main thing with this question. Treatment generally includes antiparasitics such as albendazole and or corticosteroids. Okay, so that's the main thing with that one. Other things to differentiate toxoplasmosis is that, well, you would expect it in an immunocompromised individual, and you will have potentially multiple ring-enhancing lesions on neuroimaging. So not only the little calcified granuloma there, look at this. This is a ring-enhancing lesion. It looks similar to CNS lymphoma. But how can you differentiate toxoplasmosis from CNS lymphoma? Well, CNS lymphoma isn't going to give you so many lesions as toxoplasmosis. So when you have maybe only one lesion of these on the test question, it's probably more CNS lymphoma than toxoplasmosis. Toxoplasmosis, it'll tell you that the patient has HIV and the whole thing, immunocompromised for sure. But yeah, that's about it. Let's go on to the next question. So we already got that. Neurocystic sarcosis, more in endemic areas such as Central, South America, and Sub-Saharan Africa. And that's about it. Let's go on to the next one. So this next question here is, I'm going to show you the image. So they're showing us this image. This is a female with this hair loss. So you can see that there is definitely hair loss here, but what's the pattern? So this seems to be the vertex, and this is more of like the frontal area of the scalp. And yeah, so you have to consider, why is this going on? As you can see, I was able to rule out several options. And they usually like to ask you, they're always going to ask this on the test, and they're going to want you to be able to make the differential of why the hair loss is occurring. So the way I found out the reason for this is that in females, when you have androgenetic alopecia, the pattern is what it says here. It is the vertex and the center of the scalp. While in males, it is the vertex, bitemporal, and also hairline, right? So yes, this woman had a androgenetic alopecia, and I chose that over alopecia areata because alopecia areata would happen in like a shorter time frame and not be progressing, I think. So this patient has been experiencing this hair loss since 4 years ago. And that also helped me rule out telogen effluvium. Telogen effluvium happens with thinning of the hair due to stressful things. It can be physical stress, it can be psychological stress, and it usually will resolve to a certain extent or completely in a year, if within a year, if the nauseous stimuli is removed. So well, not trichotillomania, because they're not telling us that the patient has a psych disorder and was found to have some weird thing in the stomach, which was obstructing the stomach, sort of thing. Not tinea capitis, because in tinea capitis you will see inflammation and a lot of erythema going on. So now let's see the table differentiated female and male pattern hair loss. So I already gave you the main features for both of them. Just gonna focus now on management. So the way you manage a male hair loss, androgenetic hair loss, you remember minoxidil works wonders for males and females. And yeah, minoxidil is probably always going to be a right answer with hair loss. But in males, you can also add finasteride. So finasteride will block the conversion of testosterone to DHT, dihydrotestosterone, which will be its most active form. And that's the main thing with this one. So now let's compare the androgenetic hair loss with alopecia areata. So alopecia areata, this is pretty, yes, clear. If you see this picture, you're like, what's going on here? It looks like a perfect circle here and another perfect circle. This isn't the usual pattern. Now let's compare it to this other one. Well, look at this image. It's a great image. Stage 1 right here. It becomes this in males, and then I can't, well, this gets worse in stage 3. Okay. So yeah, anyone seeing this, if you know stage 1 is happening, just go ahead and start the minoxidil right away, because the more it progresses, the least possibility to basically stop or reduce the progression. And that's it for that one. Let's go to the next question. This next question is basically, yeah, important, because if you have a patient that had a stent placed and all of a sudden, let's say wherever the stent was placed, you know what EKG territory that was, because if you have a stent placed in the anterior descending artery, you know that that's going to be the usually leads V1 through V4. If it's the left circumflex, it's going to be leads V5, V6, AVL, and lead 1, or lead D1, as we also call it in other parts of the world. And if it is the inferior wall, or sometimes called posterior wall, or right coronary, it's going to be leads 2, 3 AVF. So what happened with this patient is basically the patient had a bare metal stent placed 2 weeks ago, and now he's coming in with ST elevation, which is significant, 2 millimeters, and leads 2, 3, and AVF. So what is the most likely diagnosis? Thrombosis, right? You think there was acute thrombosis of the stent. That was the right answer. So I don't think there's much more to add to this question. Maybe add that stent thrombosis typically presents as ST elevation, myocardial infarction, usually within the first month after stent placement. So premature discontinuation of antiplatelet therapy is the most important factor associated with stent thrombosis. That is why a interventional cardiologist, or cardiologist in general, will always stress so much when they put in a stent or several stents and the patient is lost to follow-up, or the patient basically comes back saying that they didn't know they had to take aspirin and a P2Y12 inhibitor, because that's a time bomb basically waiting to happen. So that's about it for this one. Remember that bare metal stents will require the antiplatelets for way shorter duration. A patient should not have a bare metal stent unless there's a contraindication for the newer stents, because bare metal stent has a very high risk of closing up initially. And yeah, so let's see what else we have here. Dual antiplatelet therapy with aspirin and P2Y12 blocker is recommended for at least 6 to 12 months following placement of either drug-eluting or bare metal stents. If necessary, treatment can be limited to 1 month following bare metal stent placement in patients with high bleeding risk, impaired compliance, or planned surgical procedures. Premature discontinuation of dual antiplatelet is the most important risk factor, as we mentioned, and that's it. Let's go on to the next question. This other question, let's see if we can. Okay, this is a patient that had acute myeloid leukemia, had completed induction chemotherapy 2 weeks ago, and is now coming in because the patient is febrile, 38.7 Celsius or 101.7 Fahrenheit, and the patient has oral mucositis. Abdomen is soft, but with marked right lower quadrant tenderness. And basically, they maroon colored liquid stools. Patient has bowel movement heme positive, anemic with hemoglobin 8.2, platelets of 70,000, and leukocytes of 800, with neutrophil percentage of 25%, blasts 22%. CT scan shows wall thickening, intramural edema, pneumatosis of the cecum and ascending colon, and no localized fluid collection or free air in the abdomen. They took cultures of everything, and that's pending, which is the most appropriate next step in management. So the main point here is that this patient with acute myeloid leukemia has a frequent complication after chemotherapy, which can be life-threatening if not if the patient is not well educated on these things. So chemotherapy poses the risk, of course, that within those 2 weeks after that, most of these or many of these medications can induce a pancytopenia. But pancytopenia alone isn't the problem. It's when you have usually the neutropenia. And when you get into severe neutropenia, even worse, right? So this patient has severe neutropenia, which would be an absolute neutrophil count less than 500. So if you know that leukocyte count is 800 and 25% of those are neutrophils, it means that 1/4 of the neutrophils of the leukocytes are neutrophils. So 800 divided by 4 is going to give you 200. So only 200 neutrophils in a febrile patient. You cannot assume it's something else. This is called febrile neutropenia. And with these findings in the colon, it's called typhlitis. So typhlitis is something that, of course, you have to treat with antibiotics. Don't dare to do a digital rectal examination or put in anything up the rectum because you can literally perforate the rectum and you can worsen the bacterial translocation in this patient. So the answer here is antibiotics and bowel rest. That's what you want to do. And here you have some more information on the typhlitis. So let's just add some information we might be missing. Yes, it's associated with high mortality. These patients with typhlitis, like you don't want your nurse to recommend, hey, this patient is having diarrhea. Can I put in a rectal tube? No, please don't. Don't do that. Don't dare do that. And please explain that that's going to risk increasing mortality a whole lot, of course. So what else do we have? The diagnosis, we already talked about the neutrophil count, the CT scan of abdomen and pelvis showing those findings we just mentioned. And of course, you always have to rule out Clostridium difficile, get blood cultures, get stool cultures, and management is fluid resuscitation, bowel rest, plus minus NG tube. Okay, so NG tube, you can consider that just with precaution, right? But definitely nothing through the rectum. You want broad spectrum antibiotics with 15 plus metronidazole. And if complicated cases such as bowel perforation or uncontrolled bleeding, okay, you'll have to operate, right? And that's it for this one. Let's go on to the next one. This next question I got incorrect because I didn't pay that much attention to the timing. So this is a patient that basically is a 35-year-old male with depression, and the patient was started on SSRIs. So he was started on sertraline. After, let's see, at the patient's 2-week follow-up, he is tolerating the medication well, but symptoms are unchanged. So they increased the dose to 100 milligrams, which is still in the therapeutic range. And the patient called back 2 weeks after saying that he wanted another medication, but he mentioned that he is sleeping better and eating better, but he still feels depressed. And when I saw this question, I'm like, okay, so I just assumed, okay, the sertraline has worked a little, but still depressed. So we have to improve the treatment. So let's go ahead and let's augment therapy with aripiprazole. But what I didn't maybe analyze in my brain is you don't augment these therapies. Remember that SSRIs take time to work. So 2 weeks is not enough. You want to have a complete trial, I think, of 4 to 6 weeks or 6 weeks. And after that, yes, if you are in the same spot as we are here, okay, you can maybe augment. So 6 weeks, you need an adequate antidepressant trial of about 6 weeks at the therapeutic dosage. So inadequate dosage or duration is a common reason of perceived inefficacy. So you have to remain calm, stay collected, and be able to explain to your patient that you're slowly getting there. Of course, if your patient is actively suicidal or having any concerning red flags, they might need to be admitted to the psych ward, etc. Right? So patients with depression can be mistakenly labeled as treatment resistant if they fail to receive adequate antidepressant trial. So antidepressant should be continued for at least 6 weeks at a therapeutic dosage before considering medication augmentation or switching. So my option was, what I marked was option A. What did it say about A? Patients should receive an adequate trial of monotherapy before considering augmentation with a second medication. Crystal clear. Nothing else to say about that. Let's go on to the next one. So this question I answered real quick because this was a bias, because I recognized this image. So I had already seen a question in the past, which was actually talking about actinic keratosis. So it was talking about actinic keratosis and explaining how a very large percentage of patients with squamous cell carcinoma had a preceding actinic keratosis diagnosis. So it was basically stating that actinic keratosis is a pre-malignant condition that, if left untreated or unsupervised, can convert into squamous cell carcinoma. So they had this image here just to show the student that if you don't treat the actinic keratosis, it can become this right here, which was squamous cell carcinoma. So I just see this image right here, and they're asking me what is the most likely diagnosis for this non-healing ulcer. So immediately I marked squamous cell carcinoma. I didn't have to read much, right? So we'll see what the pearl here is, which we sort of touched already. So that's why I answered, well, 39 seconds. It still took me a little while. I always went and read this. I didn't want to be, be tricked in any way. So you can see here, let's see the educational objective: tender, bleeding, or ulcerated papules, plaques, or nodules in sun-exposed areas or areas of chronic inflammation or scarring merit prompt evaluation for cutaneous squamous cell carcinoma. That's it. Very clear, crystal clear. And what else can we add here? Wow, that's crazy. Look at this. Squamous cell carcinoma frequently arise in chronically sun-exposed skin. Okay, scalp, neck, pinna, and lower lip. No, I said this was crazy because I thought sort of confused pinna with the tympanic membrane, and I'm like, how's sun gonna enter there? But pinna was just telling you about, I think, the tragus and antitragus Latin words for basically the ear. And yeah, there's other risk factors such as exposure to ultraviolet therapy, phototherapy. So watch out with these people that go to what is it? These tanning places. Just go to professional places. Other things are radiation, industrial carcinogens like arsenic, smoking, immunosuppressive treatment, and rare inherited disorders like xeroderma pigmentosa or oculocutaneous albinism. Okay, if anyone here is watching, I have a question for you guys. Just out of curiosity, because right now we live in Savannah, Georgia. There's a whole lot of insects and gnats. So I use the repellent because if not, they eat me alive. I try to use the natural product. It has a lot of citronella. It has citronella and other things, but its main thing is citronella. So although citronella is natural, well, arsenic is also natural. So do you know if citronella, like having a lot of citronella in your body, can generate any problems? That would be interested for me to know. So let me know in the comment section below. This will not be on your test. This is just curiosity. And also curiosity to know if anyone ever sees this video. It would be crazy if someone answers this because I think that I might be the only one seeing my videos potentially. So let's go on to what else. If we have a suspicion for skin cancer, you always have to do a biopsy. So biopsy is required, of course. You can do a shave, a punch, or excisional biopsy that extends to at least the mid-reticular dermis being ideal. So, okay, so you have the epidermis, then you have the epidermis with the dermis connection, then you have the hypodermis, and the dermis differentiates in two. I think the first part of the dermis is sort of, yeah, more squishy, softer, and then the more deeper part is the reticular dermis. So correct me if I'm wrong, but in summary, yeah, you want to be able to get there deep enough. Imagine you do a biopsy which is very superficial and you can't even, like, the cancer is deeper than where you got. It's not gonna help you in staging. So you want to get there deep enough. And let's just show you an image of actinic keratosis. Yeah, this is an image of actinic keratosis. Some of these, you actually, when you feel the skin, you might not even see it clearly, but you feel it and it feels a little bit like sandpaper-ish. Calciphylaxis, that's just like dystrophic calcification. And why are we seeing this? This can happen with warfarin, I think. Let's see what else it says here. Calciphylaxis, end-stage renal disease patients on hemodialysis with elevated calcium phosphorus product. So I guess it generates precipitation and generates those things. Extremely painful subcutaneous nodules that can progress to necrotic ulcers. And tophi is going to show you the white little chalk usually. If this opens up, it gives like a white chalk. And that's the tophi right there. That's hard. You touch that and it's pretty hard. And pyogenic granuloma is a big crater ulcer. So, oh no, this is, oh, okay, no, see, I was confusing pyogenic granuloma with pyoderma gangrenosum. So pyoderma gangrenosum is the large ulcerative crater. Pyogenic granuloma is a benign vascular tumor of the skin and mucosa presenting as erythematous dome-shaped papule that bleeds easily. So they frequently develop over a period of a few days to weeks. This is pyogenic granuloma, okay? Not very nice looking in general, not very aesthetic, but not very bad, okay? Let's go on to the next question. This other question is basically just telling us about a patient with acute myeloid leukemia on combination chemotherapy for the past 2 days with nausea, vomiting, saline infusion at 100 cc per hour with measures to prevent the tumor lysis syndrome. So the patient is on resburicase and on ondansetron. And we have labs at admission. We have labs now. So interesting to me that the urine output was only 50 cc per hour. So this patient was being given 100 cc per hour IV fluids for about 2 days, and it's just urinating half of that. So what's going on? So then I went through the question again and I see that the patient is vomiting. So if the patient is vomiting, right, they don't put these things on the question just because. So it says nausea and several episodes of vomiting. So this patient seemed to me like the patient was being dehydrated by the vomiting, and maybe we weren't given enough fluids. And that might have been the reason. The patient was having an elevation in creatinine from 1.1 to 1.3, and why maybe the phosphorus wasn't going down. And yeah, explain several things. So that was my reasoning. And I thought the right answer was increased normal saline for goal urine output over, well, between 80 and 100 mLs per hour. And yes, that was what you want. So that's the importance of patients with tumor lysis syndrome, to have an adequate evaluation of hourly diuresis. You don't want these patients just to be peeing in the bathroom and you have no idea what's going on. Okay, you want to know how much they are urinating. So here we have some risks for tumor lysis syndrome. Yeah, so go through it, but I'll just go through those with high risk for tumor lysis syndrome. Are going to be, high means more than 5% risk, and those are going to be ALL or AML with a blood count over 100,000. Remember that leukocyte count above 50,000 is already called hyperleukocytosis. So above 100,000, of course, you have a lot of way too many cells. You risk a lot of things, including there's hyperviscosity syndrome associated to that. And of course, when you give the chemotherapy, imagine all those cells breaking off, sloughing off. The risk for tumor lysis syndrome is going to be very high. Other things with high risk are going to be certain lymphomas, such as high-grade Burkitt lymphoma, or intermediate risk disease with elevated creatinine, uric acid, phosphorus, or potassium. How do you prevent it? You give intravenous hydration, you give prophylactic resburicase, except in G6PD deficient patients. So question for the audience, I don't have an answer for right now. What is the problem of giving resburicase in G6PD deficient patients? Okay, you tell me. And then you have intermediate risk and low risk. And yeah, I won't go through those. We already got the learning pearls from here. Let's just focus on maybe another question. When would you do phosphate and potassium binders? And when would you do hemodialysis maybe? Let's just focus on those. Let's focus on D and A. So in TLS or tumor lysis syndrome, hemodialysis is indicated in patients with anuria, volume overload, or severe electrolyte abnormalities such as persistent hyperkalemia, calcium phosphate product above 70 milligrams per deciliter squared. Okay, so I never calculate that. Calcium phosphate product over 70. Okay, good to know. Despite optimal therapy. And the other one was phosphate and potassium binding therapies are recommended in patients with tumor lysis syndrome with phosphorus over 6.5 and potassium over 6. Okay, now let's go on to the next question. This other question is a 58-year-old woman, which is obese, a BMI of 32, and she just found a tender nodular cord palpated along the inner upper right thigh, with no skin changes and no ankle edema. They tell us that her creatinine is 1.3 and hemoglobin A1C is 6.7. Which of the following is the best next step in managing this patient? So this question I got incorrect because I erred on the side of maybe thinking, oh, high value care, like our patient with the initial, what was it, ankle sprain. I thought that, oh, maybe this patient, it sounds like thrombophlebitis, right? And I'm like, okay, maybe if it's thrombophlebitis, you give cold compresses and low dose aspirin, that's it. But I also compared that and contrasted to what we do in our hospital. In our hospital, when you have thrombophlebitis, you always get the ultrasound, venous duplex ultrasound to rule out DVT. But this was my brain playing a trick on me because I said, okay, thrombophlebitis is usually superficial, and this seems clinically like thrombophlebitis. Let's not waste the research of the ultrasound, right? But no, the answer is yes. You always do a venous duplex ultrasound when you suspect, even when you have thrombophlebitis, because you want to rule out that this isn't extending into the deep venous system, because that would be a problem, or there is DVT, deep vein thrombosis associated to it. So well, first, clinical features of superficial thrombophlebitis. So there is tenderness, pain, and duration, and/or erythema along the superficial vein. Possible palpable nodular cord within affected vein. Fever and purulent drainage suggest suppurative thrombophlebitis. So I've seen a lot of thrombophlebitis, but I don't recall seeing it recently any, or don't recall any suppurative thrombophlebitis. Okay. So what are indications for venous duplex ultrasound? That the superficial vein thrombosis extends more than 5 centimeters in length, that its proximity is less than 5 centimeters to the deep vein system, for example, saphenofemoral or saphenopopliteal junction, that there is involvement of great or small saphenous vein, that it is more in the lower extremity, that there is more lower extremity swelling than expected, and that superficial phlebitis following vein ablation therapy, laser or radiofrequency. So if there's vein ablation therapy and there is superficial phlebitis, just do the ultrasound. So those are the main things for this question. Let's see why it wasn't option A. So, okay, patients without DVT, once you rule it out with the venous duplex, can be treated with treated for superficial vein. What is it? Superficial venous thrombophlebitis with leg elevation, warm or cold compresses, and NSAIDs for 7 to 10 days. Now let's go to question 10. This is an interesting one. This is a 19-year-old female. She started on oral contraceptives, and right after she started on the oral contraceptive pill, of course with estrogen and progestin, she notes now that she's having multiple episodes of thin discharge accompanied by occasional mild bulbar irritation. The discharge improves with probiotics and douches, but then recurs after a week. It is thin, slightly malodorous, clear yellow discharge throughout the vaginal vault. And wet mount microscopy shows numerous epithelial cells and occasional polymorphonuclear leukocytes. pH is 7.2. Pregnancy test is negative. So I got this question correct. As you can see, I was between two options. One was physiologic leukorrhea, and the other was candidal vulvovaginitis. So I have to tell you a nice little story. Well, yeah, not that nice probably. When I was a medical student in Costa Rica, if you ask me what is the worst smell I have ever smelled in my life, it was on my OBGYN rotation as a medical student. We're talking many years ago. And I was in this rotation, and as a medical student, and the doctor actually was seeing the patient with the speculum, right? And the doctor tells us to come closer. And he basically tells us, look at this, look at this. And he basically tells us to look at it. And he also basically does that this time, like smell it, right? So, well, I did understand that good physical examination involves, of course, smelling different humors or liquids that come from our body. And I smell it. I'm like, right? And I never, nothing of this moves me usually. And I smelled it and I'm like, wow. And then I ask the doctor and I tell him, was that patient okay? When he finishes, and he was like, yeah, she was great. She was fine. And I'm like, what's that? Is that normal? And he's like, yeah, physiologic leukorrhea. And I'm like, wow, like, are you sure? He's like, yeah. And I'm like, so I'm not sure. Like, well, he told me that was physiologic leukorrhea. But as you can see, if that was the test, that was probably not physiological leukorrhea. That was probably candidal vulvovaginitis or something else going on, because yeah, smell was pretty bad. And the reason I tell you this story is because oftentimes physiologic leukorrhea can be confused with other things going on. So yes, physiological leukorrhea can be a little malodorous, okay? And it can happen, but not necessarily going to be pathologic. Of course, the wet mount microscopy helped out ruling out other things, and that was it. So how can you differentiate physiologic leukorrhea from candida vulvovaginitis? Well, the vulva and vagina will be erythematous. The secretion is now thicker. It's not so liquidy. It's now thicker. And remember the description of cottage cheese, right? That's part of its description. Okay, so let's see what else we have here. Bacterial vaginosis. Remember the clue cells, which is the epithelial cells with the what is it? The with the bacteria, Gardnerella vaginalis, all in there. Um, pH will be higher in bacterial vaginosis. Candida, we already talked about it. Acute cervicitis. This is how it looks. I think this, if I had to say the single picture or image on UWorld that is the most graphic, I think this is one of the most graphic. I don't know why it's like you see this, and this is a good thing to show anyone who is practicing non-safe sex without a condom, without taking precautions of who your sexual partners are. So definitely you want to avoid these things, right? If possible. And now we're going on to the next question. This next question is, okay, I got it right, but I wasn't sure why I got it right, I think. Oh no, yeah. So this is a patient basically with rheumatoid arthritis. So they're giving you the physical of rheumatoid arthritis. They're giving you some labs showing you mild leukopenia, elevated C-reactive protein, elevated rheumatoid factor. And they're asking you, well, they're telling you the patient did well on non-steroidal anti-inflammatories. And now the question is, what's the next step? So once you make the diagnosis of rheumatoid arthritis, you want to treat the patient. You don't want to rely on steroids long term. You don't want to rely on NSAIDs. You want to do a DMARD, disease-modified anti-rheumatic drug, I think. And the main one for rheumatoid arthritis is methotrexate. Most of the questions, if you have rheumatoid arthritis and methotrexate is there, it's probably going to be the answer. But just for your consideration, if you have mild rheumatoid arthritis, you can also consider sulfasalazine or hydroxychloroquine. But probably the test won't do this to you, I guess. Put those three in the picture. Oh yeah, look at sulfasalazine. But well, let's see what else this says. So rheumatoid arthritis, we already talked about it. Of course, more or equal to 5 inflamed joints, elevated CRP and or ESR. Oh, interesting in this question was that the rheumatoid factor was negative. That doesn't mean much because you don't need to have an elevated rheumatoid factor. Or even what else? Rheumatoid factor for you to have rheumatoid arthritis. So that's for you to consider. And yeah, as it says here, methotrexate for moderate to severe disease, and for mild, you can do sulfasalazine or hydroxychloroquine. And other than that, we're going on to the next question. So next question here. Okay, this is a 42-year-old man with heartburn for the past 3 months. It's almost daily and has nocturnal awakening because of regurgitation at least twice weekly. So they're telling you what's going on. They're telling you this patient has GERD. The GERD is being problematic. It has awoken this patient at night, and the patient has a dry cough. Guess why? Because of the GERD. The GERD goes and irritates a little bit the vocal cords, and you're having cough. So GERD is a way more common cause of cough than people would think. And the patient tried over-the-counter antacids with no significant relief. So they're telling you, okay, the patient tried over-the-counter, which you know that over-the-counter it does not include PPIs. So let's do what we actually have to do, which is the PPI. That's the end of the story here. That was the right answer. Just do the PPI. The other tough decision to choose from is, do we have to do an upper endoscopy right now? So remember that upper endoscopy is only if you have certain features, in general, red flags or age. If you start having these symptoms after age, I think 40, age 50, just go ahead and do the PPI because there might be a cancer there, right? So alarm features for GERD that require an EGD prior to a PPI trial. So you have here age above 50, dysphagia, weight loss, anemia, hematemesis, or melena, failure of PPI trial for 4 to 6 weeks. Okay, and additional features of GERD which may indicate severity but not require EGD without PPI trial. So extra esophageal manifestations, nocturnal symptoms, and non-cardiac chest pain. Okay, it's just telling you severity but not necessarily EGD without PPI. Okay, and that's it for this question. Now let's go on to next question. Or before that, when will you do barium swallow? So it has low sensitivity for mild GERD and is usually not indicated for evaluation of uncomplicated GERD. It is most sensitive and specific to diagnose strictures and evaluating patients with dysphagia. Next question, next to last, is a patient that has the mnemonic wet, wacky, wobbly. Doesn't have all of them. So I just saw that this patient was a 65-year-old man. Usually the wet, wacky, wobbly is something you see with normal pressure hydrocephalus. And there's another condition I recently had a question about that looked pretty similar to wet, wacky, and wobbly, which was actually phenytoin toxicity. So phenytoin has many toxicities, of course, but part of those toxicities are wet, wacky, wobbly. So that's for you to have in your differential. And remember that if a patient has normal pressure hydrocephalus, it does not mean they will always have the entire triad. So this patient in particular was wacky and wobbly with no incontinence, so not wet. Okay, so but despite all that, yeah, that's the main things he had. So easy diagnosis, normal pressure hydrocephalus, and that was it. And I think, yeah, we already nailed the main points. Wet, here you have wet, here you have wacky, and here you have wobbly. And of course, that's part of the wacky is cognitive dysfunction. And you can have upper motor neuron signs in lower extremities. How do you diagnose it? Well, there's marked improvement in gait with spinal fluid removal. So Miller-Fisher test. So that's a lumbar tap. So interesting how Miller-Fisher put his name on several things. So there was also Miller-Fisher, I think, neuropathy, something like that, that it was like, remind me in the comment section if that was something Miller-Fisher was like a variant of optic neuritis, something like that. But well, you can also do the Miller-Fisher test, which you have to remove not a little lumbar or CSF fluid. You have to remove about 30 to 40 cc. So if you have done lumbar punctures in the past, remember that about 20 drops was 1 ml. So you would have to remove 20 drops times 30, about 600 drops to get to the 30 mLs. So a whole lot of time there because usually most of my lumbar or my spinal taps, the little drops come rather slowly. So, okay, so that's how you would basically diagnose it. You can also see it on imaging, enlarged ventricles out of proportion to the underlying brain atrophy on MRI, and treatment is ventricular peritoneal shunting. And that's it for that question. What's the pullback test? And mini mental state exam may be abnormal but are non-specific. What's the pullback test? Pullback test is, let's see, stand. Let's see if I can. Pullback test. Stand behind the patient and pull back on the shoulder so as to unbalance him or her. Normal response is to fall 2 to 3 steps back and regain stability. Patients with extrapyramidal symptoms such as Parkinsonism often need more steps to regain stability or even fall backward. Okay, so now I'm putting a name to something I remember seeing by neurologists in Costa Rica, which they would often do this without much explanation. They would just get behind the patient and like pull them and see this. So that's nice to know that. Well, that can be abnormal as a false positive here in this specific thing. And that's it for this one. Let's go on to the next one. Last question we have is a patient with sinusitis, 32-year-old male. But here is the importance, the timing of the sinusitis. So remember, you give it about a week. If the patient has not improved in a week, such as this patient felt he was improving for about a week, but now has 1 day of fever, chills, purulent nasal discharge, and facial fullness with pain. So the patient is also febrile with 39.2 Celsius or 102.5 Fahrenheit. So you know this is a problem. You know that this isn't the sinusitis you see in clinic, and you're like, okay, well, you see this patient in clinic. You tell this patient, we're gonna treat symptoms. This is probably a virus. Okay, 60% of it or more, 60 to 80% of it is gonna be viral. If you improve, great. Don't even call us. If you don't improve in a week, let us know. Most of your patients won't call back because they have improved. This is the patient that calls back and says, I'm feeling horrible, I'm feeling worse. Why didn't you give me the antibiotic on the first occasion I went to the hospital or to the clinic? And this is the one you say, okay, now you probably do need an antibiotic. And what's the antibiotic of choice? It's amoxicillin clavulanate, unless you have any contraindication. So indications for antibiotic therapy for suspected rhinosinusitis. We already talked about persistent symptoms lasting more than 10 days, or severe symptoms such as high fever, purulent nasal discharge, or facial pain for more than 3 days, or worsening symptoms for more than or equal to 5 days after an initially improving viral upper respiratory infection. And current guidelines recommend amoxicillin clavulanate for 5 to 7 days in these specific patients. And yeah, not amoxicillin alone because you want the clavulanate, which in Latin America is known as a suicidal inhibitor. So yeah, it works as a decoy so that the amoxicillin can do its wonders even better. And if the patient is maybe allergic, you can maybe do macrolides or something. Yeah, so trimethoprim sulfa and second or third generation cephalosporins. Let's see. Oh no, they're not recommended. Sorry. So don't think about those. Don't think about macrolides, TMP, SMX, and second and third generation cephalosporins. If you cannot do amoxicillin clavulanate, maybe think about doxycycline and respiratory quinolones. Okay, so that's about it. And that's when would you do sinus X-rays? You almost never do it. You would do sinus X-rays if you let's see when they are not indicated in acute bacterial sinusitis. Sorry. CT is preferred over sinus X-rays in patients with acute complicated sinusitis with vision abnormalities, periorbital edema, severe headache, or altered mental status. CT is also preferred in patients with uncomplicated bacterial sinusitis with persistent or worsening symptoms after antibiotic treatment to evaluate for air fluid levels, which indicate chronic sinusitis. Okay, there you have it. And see you in the next one. Hope you liked it. If not, also let me know. Comments, feedback, opinions, everything. Let me know. And my idea is to, yeah, act. Sharing is caring. So play out one of the phrases I love, which is sharing is caring. See you in the next one.